from the asked me whether I would want to give this talk, I thought, well, that's great. Let's talk a little bit about metabolism and diabetes and obesity. And then when I started to prepare the presentation, I sort of hated myself for saying yes, because it's such a broad field that you don't know where to start and where to end. So I decided not to go for some details, but to give a broader overview, and also to reach out into fields that are sort of related to metabolism, but strongly influence metabolism. So it's going to be a little bit basic, and what I'm trying to do is to give you a couple of ideas in which way we could go in the future as imaging community, what to image in diabetes and metabolic disease. So this is the overview, and I'll show this slide from time to time so that you know where we are in the presentation. And I'll start with diabetes, and I'll tell something about obesity, metabolic syndrome. A couple of novel insights. It's not really novel. That's what has been happening in the last 10 years, let's say. A couple of things that are happening in imaging metabolic disease, and in conclusion, obviously. So to start with, it's going to be diabetes. Diabetes mellitus is actually a disease that's composed of two words. One is the Old Greek word and the Latin word, which means sweet flow. Why is it called sweet flow? So one thing is that this disease has actually been reported to be diagnosed by the sweet taste of the urine in antique sources from India, Alexandria, and Rome. So it's been used all over the world, this way of diagnosing it. And the disease has been known for thousands of years. And this is a very famous painting of Jan Steen, the pistkijker. For those of you who don't speak Dutch, it means the pee watcher. And this guy is actually, well, he's not tasting at this point in time. I think he's not really going to drink it, but people actually used to put their fingers into the pee and lick their finger and see whether it was sweet or not. Usually, the glucose level is maintained by eating, and insulin is actually regulating it. So insulin is a hormone that is produced in the beta cells in the islets of Langerhans in the pancreas, in the so-called endocrine pancreas, and it's actually released upon ingestion of food. I'm going to tell something about beta cell imaging on Thursday, and there I'll go into some more detail concerning that. But here I'll keep it a little bit more general. And what you see is then when you eat, that's the red line, insulin is going to be secreted. Then here we have a second glucose peak, insulin is going to rise, and then it's counter-regulated. And this is the circadian rhythm of insulin and food intake that we usually have here in Middle Europe. Basically, the disease diabetes mellitus is caused by a disbalance between the glucose or food intake and insulin secretion or insulin action. So if you don't secrete insulin, you can't regulate your glucose levels in the blood. The glucose levels are going to rise. If the insulin does not work in the peripheral organs where it should be working, glucose is going to Okay, so if insulin is not there or doesn't work, the blood glucose or the glucose from the blood cannot be taken up by the peripheral tissues where it should go to. So the blood glucose level is rising, and the high blood glucose levels on the long term will eventually lead to chronic or acute organ damage, depending on how quickly those high blood glucose levels actually appear. This is a Okay. Which is the storage form of glucose in the liver. Okay. Oh, you. Oh, it doesn't matter. Yeah. Oh. Yeah, right. It's the battery insulin is dropping. So basically, the liver then can store glucose for later use, or insulin stimulates the uptake of glucose into tissue, into all tissues more or less. And then the blood glucose levels are going to drop. If they're normal, everything's fine. If they are going to drop too far, there will be a counteraction in which glucagon will be produced by the alpha cells that are also part of the islets of Langerhans in the endocrine pancreas. Glucagon is secreted, stimulates actually breakdown of glycogen into glucose, and the glucose levels are going to rise, and then you have the homeostasis again. So that's the basic principle, very simple, very easy. In fact, it's much more complicated, but you'll see that later. If you have diabetes, these are the symptoms you're actually getting, and a couple of them are quite interesting, like weight loss. Why do you lose weight when you have type 1 diabetes? Everybody associates big obese people with diabetes, but in type 1 actually, because insulin is not there, there's no way glucose can be taken up by the cells, so the energy cannot be efficiently used. For example, then breath, smell of acetone. That's because you switch to fatty acid metabolism, and then it smells like acetone, and your pH in the blood is dropping, which causes Kussmaul breathing to compensate for the drop in pH in the blood, and all these things. So, and one of the things that's really important is polyuria, because that's the way we diagnose diabetes, right? So because all the glucose in the blood can actually not be taken up by the kidneys anymore, so it's going to be peed out, and that's why you have all the glucose in the urine. Diabetes is one of the major healthcare challenges we have nowadays. So the prevalence of diabetes is about, well, let's say 400 million worldwide. It's expected to rise to 600 million by 2035. These are the WHO criteria numbers. There are other numbers around also. And interestingly, up to 15% of the national annual healthcare budgets are related to diabetes care in high prevalence countries. 15%, which can even rise up to 40% in high prevalence countries in the coming 10, 20 years. So it's really a problem we have. And this also includes the treatment of the complications like kidney failure, retinopathy, diabetic foot, high blood pressure, cardiovascular disease, and so on. So it's really a healthcare challenge. And this is why I think imaging in diabetes can help us to better figure out what's happening there. And everybody believes that diabetes is very simple, very straight, easy to treat because you can give insulin or anti-diabetic oral drugs. But it's much more complicated, actually. So in the good old times, life was easy because we had two types of diabetes. You had insulin-dependent diabetes mellitus, which was also called juvenile diabetes. So that's lean people who don't produce insulin, who have to inject insulin. And then you had non-insulin dependent diabetes mellitus. These were the older people, older population, a little bit obese, but they didn't need to inject insulin, and life was easy. Unfortunately, it's a little more complicated. So we do have type 1 diabetes, how it's called nowadays. So insulin-dependent diabetes mellitus is something we don't say anymore. Basically, it's immune-mediated, so it's an autoimmune disease where beta cells are actually killed by your own immune system, and then they don't produce insulin anymore, they're gone. They're going to die. That's at least what people believe. Can also be idiopathic. Some people have it and nobody knows why. Type 2 diabetes with or without obesity means that you have peripheral insulin resistance, so the tissue does not react to insulin. You make insulin, you have glucose, but the glucose uptake into the peripheral tissues doesn't work because they're insulin resistant. Meaning that you might produce too much insulin, but which doesn't work actually, so that's hyperinsulinism. But also, it's a relative lack of insulin. So even though you have very high levels of insulin, you would need more to overcome the insulin resistance. In the end, it's lots of stress for the beta cells, and you'll have an impaired insulin secretion because the beta cells can't work like that. It's sort of overwork. It's stress. They're going to undergo apoptosis. Then you have gestational diabetes. When women are pregnant, the additional need for insulin is not sufficiently answered, and they actually get type 2 diabetes during pregnancy. After pregnancy, usually it's over. But they have a higher risk of actually getting T2D on the long run. Then you have MODY, which is the maturity onset diabetes of the young, meaning it's type 2 diabetes in young people. This can be a syndrome. I think we have nowadays 11 types of MODY based on genetic and other characteristics. So that's young people getting type 2 diabetes. But there are also many others. But basically, this doesn't look very much more complicated than NIDDM and IDDM. But there are a couple of really strange things. There are patients with onset of type 1 diabetes at the age of 40, 50, 60, 70, which is called latent autoimmune diabetes of the adult, LADA. I like this one. It's actually 4x4 produced by the Russian car producer LADA. It's a very good off-roader, actually. But this is something that people didn't expect 30, 40 years ago, because type 1 was loss of beta cells because of the autoimmune disease. But then you have lean patients, not obese, who have peripheral insulin resistance and actually type 2 diabetes. You have young patients with features of type 2 and type 1, so they may be obese, peripheral insulin resistance, but also loss of beta cell mass, which is type 1, an autoimmune disease. And we are finding more and more of those things. And this is a classification from the American Diabetes Association from 2008. So this is the list of different types of diabetes. We have a couple of more nowadays, so it's really confusing. There are lots of different types of diabetes out there. That's a rough idea. That was actually meant to give you a rough idea what happens in diabetes. We'll go into a little bit more detail later on, because diabetes, obesity, metabolic syndrome, that's all linked, actually. And we'll move on with obesity. So obesity actually is measured by the body mass index, meaning you take your body length and you divide it by twice, you take your body weight and you divide it by twice your body length, which then gives you a measure of kilograms per meter square. And these are the numbers that are used in Europe. So until 25, it's normal weight. Above that, it's overweight. I'm overweight, by the way, so my body mass index is 25.7. Does everybody see that? Okay. Thanks. Thanks. But the point is that when you have severe or morbid obesity, this will reduce your life expectancy by 2 to 4 years if it's severe. But if it's really morbid obesity, it can be 10 years in average, meaning that some people won't die premature, but others will lose 20 years. Usually, obesity is caused by disbalance of food intake and energy expenditure. Very simple. One of the stories you always hear, especially from patients, is that they have a slow metabolism. In the scientific community, this is not in general accepted. Slow metabolism is scientifically not valid. But another thing that people will also tell you is that they have big bones. Big bones is also not scientifically accepted. Basically, obesity is caused by too much food intake. There are a couple of exceptions, because you can have syndromes, genetic syndromes, that will cause obesity. But basically, most people with a big belly eat too much and drink too much. Very simple. What are the risk factors to become obese? It's diet, sedentary lifestyle, so we don't do sports, we don't walk, we just take the elevator. You all know that when you're in the hospital, there's this elevator, and there are people who have to go from level 0 to level 1, and they're going to wait 10 minutes in front of the elevator instead of just taking the stairs. It's just amazing. Social status, that's also interesting actually, because that has changed. Nowadays, social status, if you have a low social status, you have a higher risk for obesity. This guy in 17th century had a high risk of obesity because he had a high social status. So in the good old times, if you had a high social status, you got obese because everybody else didn't have enough food and had to work. As I already said, genetics, there are some syndromes like Prader-Willi syndrome or so where you become obese. There are also illnesses such as eating disorders, psychiatric disorders, hypothyroidism, which can also cause overweight. I can tell you one thing, if you run an outpatient clinic for people with thyroid problems, many you see per day will be obese people telling you that they have to be hypothyroid because they gain weight all the time. So it's going to be the thyroid gland. That's nonsense. There are not many people who really have hypothyroidism, and that causes overweight. Usually they want this as a diagnosis because then they don't eat too much. And another interesting thing is the microbiome, the gut flora. And I'll come back to that later. Morbidity actually includes a couple of things. Osteoarthritis, because you're too heavy. So this will kill your knees and your hips. Obstructive sleep apnea. Diabetes, cancer. A couple of sorts of cancer are actually have a higher incidence in type 2 diabetes patients. Cardiovascular disease, also associated with obstructive sleep apnea. Non-alcoholic fatty liver disease, which is caused by too much fat in the liver and might lead to liver cirrhosis. Insulin resistance, pro-inflammatory state, and pro-thrombotic state. I'll come back to that later also. This is a very good example for America first. America first. Obesity seems to be a civilization problem, in especially the Western world. Funny enough, in Japan, everybody with a body mass index above 25 is obese. So they have a different definition. But in Europe, we're doing quite well also, as you can see. But still, yeah, United Kingdom is leading in Europe, obviously. So this is quite, so we are talking about 34% of the total population being obese. That's quite something. And also, like Greece, Spain, Germany, numbers between 15 and 20%. That's really a lot. Sorry? But the point I now want to make is obesity has been known in Neolithical age also. This is actually a little figurine which is something like 25,000 years old, and we don't know whether it's a symbol for fertility and whether obese women have been attractive in those days. We don't know. Maybe that's what many people think, but maybe it's just a woman with a Prader-Willi syndrome. We don't know. But obesity has been around in the Neolithical times already. This is also a very interesting case because this is actually the Marquise of Dai. She's a lady that has been buried in China. She died 160 before Christ, and her tomb was actually found during excavations in 1971. And the cause of her death, and this is how the mummy looks like. So this is one of the best preserved mummies in the world. More than 2,000 years old. And they found that she died from an acute myocardial infarction. And the mummies usually look a little bit thinner than they have been because they sort of dry out. But she has been obese when she died at the age of 50. Died from myocardial infarction. And this is a very good example for a high social status because she was married to one of the highest people in China at that point in time. And the high social status meant she had enough to eat, enough food She gained weight and died of a myocardial infarction. So this is not really new. All the agricultural, developed, civilized cultures have that problem, and it's not really new. The fat distribution is actually also an issue that has been looked at in obese people. So we all know that women tend to have the fat a little bit lower than men, and if men have it on the same level, it's pretty big usually. And subcutaneous fat is more storage, while visceral fat, that's the fat inside your abdominal cavity, is the one that's metabolically active. And people have looked into risk prediction for cardiovascular events, for example, and the distribution of your fat does not tell much about it, actually. It doesn't matter whether you have a big hip or a big belly or whatever. It's not a distribution thing. The only really good prediction factor is the belly circumference. In men, 102 centimeters, and in females, 82 centimeters. If you are above that, you have an increased risk for cardiovascular complications. It's quite amazing. We can do a lot of measurements, blood lab values, whatever, and this is the thing we use for risk stratification. It's one of the best predictors we have. The metabolic syndrome fact or fancy. Now it's becoming a little bit complicated because the metabolic syndrome, it does exist, but nobody knows what it is. So it's not really fancy. It's fact, but we don't know what it is. So basically, when you have the metabolic syndrome, you have insulin resistance in the peripheral tissue. You have a high blood pressure, high triglyceride levels, and low HDL, high-density lipoprotein cholesterol levels, which is, as we know, a risk for developing, for example, cardiovascular disease. But we have so many definitions, and I'm just showing you 2 definitions what metabolic syndrome is, but there are many more around. And you see that they have some things in common. The central obesity is actually something I just mentioned. It's also right there. So here it's called waist-hip ratio, but basically it's the same story. And then you have to combine this with blood pressure. Then you have triglycerides and HDL here is one. Here it's 2 different factors. So we don't really know what it is. We know what it belongs to it, but the right diagnosis is difficult to make because we have many different definitions. But one of the major problems we do have is insulin resistance in metabolic syndrome. Same thing as with type 2 diabetes. It's linked. And this cartoon actually, I don't want to go into detail here, this comes later, but this cartoon actually gives you an idea what happens in your body when you have insulin resistance, because the R gives you the things that happen when you are insulin resistant, when you have insulin resistance. And it has an influence on macrophages, myocardium, on the brain, on the pancreas, on the liver. So it's immune system, macrophages, but also on muscle, fat tissue, whatever. And here I actually wanted to point out a couple of things. One thing is that in the pancreas, in the endocrine pancreas, insulin resistant reduces apoptosis of beta cells. Sounds like something, and that's very good, but usually you don't have much apoptosis anyway, and induces beta cell proliferation. Why? Because you do need more insulin, and this can only be produced by more beta cells or more active beta cells. In the blood vessels, you get an increased leukocyte adhesion, so there's an inflammatory reaction in your blood vessels. Not good. Macrophages produce TNF and IL-6. Keep that in mind. We'll come back to that later, because that's really one of the hallmarks of metabolic syndrome, of insulin resistance. As I said, there's endoplasmic reticulum stress. Something that's also interesting, the adipocytes, the lipolysis is going down. So once you have that fat stored in your adipocytes, it's going to stay there. On the other hand, insulin resistance causes increased levels of lipoproteins in the blood. So you're getting into a vicious circle. How do you treat a metabolic syndrome? Actually, you have to treat all symptoms that you have. Diet and physical activity, these are the classical lifestyle interventions. You have to control the blood glucose level with anti-diabetic treatment. you have to reduce the elevated low-density lipoprotein levels and blood pressure control. Now the funny thing is, if you're a pilot, for example, and I know the guy who's doing this for the German Lufthansa, pilots who have diabetes are not supposed to fly anymore. That's not nice. So the Lufthansa pilots always go to one doctor who's actually working close to Mainz, which is in the vicinity of Frankfurt, where the pilots are based anyway. And he actually does this. And he can keep, when he does this, and this takes a couple of weeks until they get into their metabolic balance again, and then usually they can fly for another 2, 3, 4 years before they go back and really get full-blown type 2 diabetes and are not supposed to fly anymore. So doing this, you can actually delay the onset of type 2 diabetes. Okay, novel insights in metabolic disbalance. And as I said, it's not really novel. Now I'm trying to connect all these things a little bit. Show a little bit of pathophysiology and how we can get out of our problem. So this cartoon says a fat transplant can make you obesity resistant. Sounds a little bit strange. Why should fat that you want to get rid of be transplanted so you get rid of your obesity? Well, I'll show it to you. So this is something that the nuclear medicine community has been knowing forever. The very moment we started performing PET scans, we saw this pattern of high uptake of FDG in fat tissue. And pretty quickly people said it's brown adipose tissue. Brown adipose tissue is tissue that only, at least that's what I learned in med school, that only babies and infants have. Why? Brown adipose tissue can produce warmth. It's thermogenic, meaning that, well, you can produce warmth, which we as adults don't have. It's not necessary for us as much as for infants or babies. But this has never been proven. A couple of years ago, I think it was in 2008 or 2009, 3 groups in parallel have published their findings in the New England Journal of Medicine, where they could show that the increased FDG uptake is indeed brown fat tissue. So everybody was claiming it, nobody had ever tested it, whether the hypothesis was right. And what actually happens is, at room temperature, you don't activate your brown fat. The very moment the temperature drops, you get an activation of the brown fat. But if you're obese, the activation of the brown fat is much less. So obviously, having brown fat is a sign of a good metabolic state. These are images from Maastricht University. That was one of the groups that published these, was a group that has published one of these 3 reports on brown fat. And what you see here is they've histologically proven it's really brown fat. So the surgeon has taken out fat, they have looked at it. This is really brown fat, this is white adipose tissue, brown adipose tissue, and this actually, in green, is immunohistochemical staining of UCP1, which is uncoupling protein 1. The brown fat is brown because there are lots of mitochondria in there. And mitochondria produce ATP. But UCP1 is able to uncouple the proton influx, which follows a gradient, which is used for producing ATP from ATP production, meaning that the protons there's proton influx, which only produces warmth, but no ATP. Okay, this is how thermogenic fat is working. So everybody of us should have it. Those of us who don't have it have a problem. And this is why on the first cartoon I showed you this guy saying you need a fat transplant. It's brown fat transplant, what you would need if you're obese. This is also interesting because these are patients that have been morbidly obese before and after bariatric surgery, and you see that those before had not much activation of brown fat except for this one, and after bariatric surgery, after losing weight, after responding to the therapy, they all have a little bit of brown fat. So brown fat is associated with a better metabolic state. Well, when you find those things and it's published in the New York Times, like the first image I showed you, somebody is going to pick it up and use it for economic reasons. So this is a book, and this is the guy who's written it, The Way of the Iceman. So if you use science and secrets of breath control, cold training and commitment, you're going to be very, very healthy. To be honest, if you don't use cold stimulation or whatever, and just do a little bit of sports, it's fine also, but temperature does help. And you can sell the book, actually. But there are discussions ongoing right now. So these are two websites. So this website actually is in favor of sporters that should have a cryotherapy after sporting, after training, because that'll improve your body, your physical state. While this website is saying, well, it's not proven, you shouldn't do it. And I have no idea what this has to do with cryotherapy after sports physical activity. And this is actually another interesting finding. So in 2012, I think it was, they published that they could find a myokine, so a muscle-produced protein, which was called irisin. And irisin was actually able to promote white adipose tissue into brown adipose tissue. And it has been found in mice that it works, and in rats it works also. In humans, the situation is unfortunately a little bit more difficult. So there are a couple of studies out there showing that if you have physical activity and cold exposure, your irisin levels are going up. Others can't find a difference at all. We don't really know. It may have to do with the ELISA kits that have been used. Irisin does exist, but it works nicely in rodents, but in humans it's more complicated, obviously, and we don't know what it does. So the basic idea of this stuff was you produce irisin, you inject it or eat it or whatever, you activate brown fat and you're going to lose weight. This does not work as easily as that in humans, only in mice. Inflammation. Inflammation is also a very important one. And all the stuff I'm showing there, inflammation and microbiota, is also something that can be applied in cancer, for example. Same basic principles. It's quite interesting. Metabolic disease and cancer have the same, to some extent have similar pathophysiological basics. Who in the audience has hay fever and has ever experienced a sort of an allergic fit? Does anybody have hay fever? Very heavy hay fever? No? Any other allergy? Yeah, right. So if you have hay fever and it's really bad, how do you feel? Bad? Do you get hungry? No. You do get hungry. Yeah, I'm getting hungry also. So when I have hay fever and I have one of those fits, which doesn't happen very often, but if I have it, give me a whole bottle of Ben & Jerry. Cookie dough, fantastic. You eat it and it's going much better. But this has not only to do with cooling down your nose, your mucosa there, it also has to do with the energy expenditure. You're really done when you have such an allergic fit that you're sneezing all the time and your nose is running and everything. You're completely done at the end of the day. It really kills you. Why is that? Because your immune system needs energy. Where does the immune system get the energy from? Well, very simple. The immune system switches off the energy uptake of all other tissues. The immune system pulls the energy to its cells. And this is quite interesting because the principle of this is very, very old. This is Drosophila. Drosophila has a fat body that actually has more or less in one integrated organ the functions of human adipose tissue, human liver, and immune and blood cells. So what works there? What's happening there? So this is the Drosophila equivalent of insulin. This is the Drosophila equivalent of TNF, tumor necrosis factor. It's called Eiger, like the mountain in Switzerland. This is the equivalent for lipopolysaccharides. It's called Spätzle. Does anybody know what Spätzle are? It's noodles, actually, more in the German-speaking part in Austria, Switzerland, and some parts of Germany, the southern parts. Why they have called it like this, I have no idea. And Wengen actually is one village there. So if in Drosophila you activate your insulin, you get glucose metabolism, adipogenesis, and all these things like in humans also. If you activate Wengen or Grindelwald. They're both the same. There are two subtypes of that TNF receptor or IGA receptor in Drosophila. If that's activated, it's gonna block the insulin activity. Okay, so you get hyperglycemia. You become diabetic. Same thing with Spätzle. If you genetically modify Drosophila so that it doesn't have the Grindelwald receptor anymore, you don't become hyperglycemic anymore as Drosophila. In humans, it's a comparable thing. So LPS is actually a breakdown product of bacterial membranes, TNF, tumor necrosis factor. If they activate those receptors, they're going to shut down the insulin activity. Why? Because then glucose is available for immune cells. Quite interesting, I find. Meaning that inflammation, and now we're coming back to what I showed in the beginning, TNF alpha secretion by macrophages in the fat tissue, means that insulin action, insulin sensitivity is stopped by this effect. Okay, so adipocytes become insulin resistant by this TNF effect, by macrophages that are in the adipose tissue. And this is showing the same thing, a little bit more complicated, but I actually want to emphasize on this. You have metabolic genes and inflammatory genes that can be up and down regulated. And now we're going into epigenetics. So genetics actually means what are your genes? Yeah?
So why are we always focusing, I realize that insulin is centrally important, but we don't mention glucagon ever. And I always thought, when I was taught, that these are
Glucagon, yeah. Yeah, you're absolutely right. Glucagon is one of the central things that go wrong. And for example, in badly controlled type 1 diabetes, glucagon may play a very important role. You may even get more alpha cells than what you actually want to have. So glucagon actually withholds the insulin effects that you create by injecting insulin. It's not equally well studied. I think the diabetes community has been focusing on this effect a little bit later than insulin. It was always insulin, but in the last years people have looked into that, and it indeed plays a role. But I wanted to keep things simple, so I try to focus on insulin and how the immune system actually shuts down our insulin sensitivity. And this is actually going into epigenetics. So genetics is your genes. That's sort of the hardware you have. But genes are up and down regulated and can be expressed in a very differentiated manner. And that's epigenetics. Which environmental factors influence which genes are expressed and how. And those epigenetic factors actually make that you produce or that you activate inflammatory and metabolic genes that should not be activated. So it's sort of dependent on your environment, meaning that even if you cannot really identify clear genetic factors why you should be obese and your parents have been, it can be your living environment that makes you become more obese because of epigenetic factors that shut down or overexpress certain genes while others are sort of shut down. This is also playing a role here. I have no idea how to image that, to be honest. The next thing is microbiota. So we all have an intestinal microflora. It consists of different types of bacteria, and they may be different in different parts of the guts of our intestinal system, but they do have influence on a lot of things. So influence of the gut microbiota on non-alcoholic fatty liver disease has been found. Autoimmune arthritis, obesity, metabolic syndrome, insulin resistance, inflammatory bowel disease, that's most probably not really surprising. But also immune responses to virus infections, experimental immune encephalomyelitis. Actually, there are data showing that depression might be caused by different types of microbiome. And also immune system it also has an influence on the development of the immune system. And the microbiota you have is actually passed on from your from your parents. If you have a dysbiotic gut microbiota, so several bacteria missing, other bacteria are overwhelming, what happens is that bacterial breakdown products like LPS that I just mentioned are taken up by the bloodstream and are actually flooding your whole body. Not in very high concentrations, but it's there. What does it mean? It means that you have activation of macrophages of all those immune cells in your body, and this can actually cause insulin resistance using the pathway I just described and inflammation in all tissues in your whole body, including your adipose tissue, for example, but also the pancreas and other organs. And this brings me to a pretty interesting paper. It's I wouldn't say it's ignored by the diabetes community, but everybody thinks that you have a chronic autoimmune process causing type 1 diabetes. In this chronic autoimmune disease, beta cells are destroyed by your immune system. Does anybody know how in humans insulitis, so an inflammation of the islets of Langerhans, look like under the microscope? Has anybody ever seen that? Do you know how many inflammatory cells are in one islet? 10, 15, 20. We are not talking about an infiltrate. It's just a few inflammatory cells in the islet. So there are people who say, well, is insulitis, is that something that's more than chronic? Is it relevant at all? You can ask that question. Now, Ole Korsgren from Uppsala came up with a completely different idea. I showed you the one of the first slides about microbiota, that you have different types of bacteria all over the place in your guts. Now, he came up with a different theory, which differs from our idea about autoimmune diabetes. He says there's been a big change in the microbiota of the duodenum. So 50, 100 years ago, the duodenum was more or less sterile because there was low pH and not many bacteria can pass through the stomach and survive a pH of 1 or 2. Nowadays, most probably as a consequence of our diet, the microbiota of the duodenum is an oral microbiota. So the same bacteria as we have in our mouth are living in the duodenum. Don't ask me how they pass the stomach, but that's what we have nowadays. And he actually in this model in this red model showed that breakdown products of bacteria that retrograde enter the pancreatic duct washed into the pancreatic duct, and in the pancreatic duct they can cause an inflammation. This inflammation actually causes a pretty acute inflammation, and the immune cell infiltration he saw around the islets of Langerhans was a protective immune cell infiltration, so immune cells that sort of try to shut down the immune system or control it instead of supporting inflammatory activities. I'm not sure whether this is true or not, but it's a different theory. And this theory could actually explain why gut microbiota, which has changed over the last years, causes a higher incidence of type 1 diabetes nowadays. And I think it's not a really nonsense explanation, because if insulitis is only 15 inflammatory cells per islet, or 20 or 50, doesn't matter, it's not much, then a more acute inflammation could explain why we do see an increased FDG uptake in people with recently diagnosed type 1 diabetes, because those few macrophages distributed all over the pancreas will not be visible at all. So I think it's something we should keep in mind. This cartoon actually shows how diet can influence this. And this is one of the things like we have microbiota now, and everybody's looking at it. Very interesting. People try to earn money with it. And I would like to emphasize on two little things. There's also stress-induced changes in microbiota. Also, stress can change that. Also, antibiotic therapy, for example, can change your microbiota, which can have all those influences. And this actually is something that's also quite interesting. So, Yogurt in Nutrition is a commercial website. They want to sell yogurt, and you know that we have those microbiotic yogurts. Does anybody know where they come from, how they were developed? So everybody buys them because they're healthy. At least people believe they're healthy. So what happened was that in First World War, soldiers had a problem with dysentery because of the hygienic conditions during the First World War. Some had very bad dysentery and died, and others didn't have it very badly and survived. What scientists did, they collected the stool of those patients that had survived and didn't have bad dysentery. They collected the bacteria from those soldiers, from their stool, and put them in cell culture. So when you're eating probiotic yogurt, basically you're eating 100-year-old soldier shit. Just to make sure that you know what this is. Also, there's always this question, can I test the health of my gut microbiota? Because you have different types of microbiota. Well, if you test it, you get a lot of data, but we actually don't know at this point in time what it means, whether it's good for you or bad that you do have your microbiota. There are also human studies ongoing where they use microbiota of people that don't have diabetes, for example, or other diseases, and transplant them into people who do have that disease or are at risk and see whether it has a positive influence, yes or no. Some studies show it works, some studies show it doesn't work. Basically what they're doing is they're transplanting shit from one patient to another. Okay? But basically because people don't want to eat it, it's actually done via catheter to the duodenum. But this is something that's just developing. We don't know much about this. This is something that's ongoing at this point in time. And then this is a little bit what I'm going to be talking about on Thursday also, because this is what I'm doing, beta cell mass and function. That's what I'm interested in for imaging. And I just want to show you two basics of this. So this is from a publication where they looked into the pancreata of patients that died. So these are autopsy data. But for all those patients, their metabolic state had been documented. So their glucose homeostasis has been documented. So the green, these are the patients that are obese but non-diabetic. Okay? These are the patients, yellow, that have impaired fasting glucose. So their glucose control is not optimal, but they don't have diabetes. And these are the patients that have diabetes. And their conclusion was people who don't have diabetes as compared to those that do have diabetes have a higher beta cell mass. So that's the beta cell mass as compared to their metabolic state. Okay, looks like it. The thing that interests me much more is here we have a patient who is healthy, no diabetes. This patient is diabetic, same beta cell mass. Why does this patient have diabetes and this does not? And it is not peripheral insulin resistance, because that was comparable in all those patients. So obviously it's not beta cell mass by itself that tells you whether somebody produces enough insulin. It's a combination of beta cell mass and the capacity of those cells to produce insulin. Also, when we determine the beta cell mass in pancreata, what we are doing is we stain against insulin, and immunohistochemical staining against insulin stains those cells that produce insulin and that store insulin, mainly store insulin. So it's insulin granules that you're finding. This group, actually from Piero Marchetti's group, they have used electron microscopy and a different technology to figure out how many beta cells you actually see with immunohistochemistry as compared to their technology. And what they found is that you don't see a lot of beta cells because they are degranulated. Those patients have beta cells that produce insulin, but the insulin is secreted right away because of the demand. Or it's not produced at all in type 1, for example. Meaning that anti-insulin staining will not find those cells while they are beta cells. Meaning that all our data showing that you have loss of beta cells in type 1 or type 2 diabetes patients may not be completely right. Okay? I'll come back to that on Thursday. Now, imaging metabolic disease. I'll now give you just a couple of examples, and then in the conclusion I'll give you an idea of what I think what we should as an imaging community focus on in the next couple of years. So this is from a publication where they summarize what you can do concerning clinical imaging, clinical characterization of patients with metabolic syndrome, diabetes, non-alcoholic fatty liver disease, and all these things. So you see we're already doing a lot of imaging in those patients clinically. Whether you use it or not is something that depends on your local preferences, I would say, what you're familiar with. But we have a couple of imaging technologies that are also already clinically used in those patients, mainly to predict the complications. I think we need to take it one step further and characterize patients before they get their complications. And from all the other things that I just showed, like microbiota, the inflammatory stories and all this, we might be able to provide novel therapies in the next coming years, which would make sense in the sense that if you can predict that somebody's going to respond on a certain therapy, and you can predict this based on imaging biomarkers, it would be great, because that's what we could do in the future. And this is just an example. You can do magnetic resonance spectroscopy for determining the measurable fat in the liver, for example, in non-alcoholic fatty liver disease. You can use CT by just determining the liver to spleen ratio using the density. This is NAFLD, this is healthy. You can use ultrasound and elastography to see how the liver looks like. And this gives you an idea about non-alcoholic fatty liver disease. You don't need a biopsy then, okay? This is an example. Marty will present this on Thursday afternoon of what we have done. We have looked into the FDG uptake in adipose tissue, in white adipose tissue, in visceral fat and subcutaneous fat. And if you do a hyperinsulinemic, hypoglycemic clamping and you maximally activate those adipocytes, you'll see pronounced differences between type 2 diabetes patients and healthy volunteers. And you can these differences you won't. Well, FDG is the one that's most sensitive for this kind of stuff. There's another thing, and this is also what I'm going to be talking about on Thursday afternoon. This is imaging of beta cell mass in diabetes, and we are using a GLP-1 analog, Exendin, here to determine beta cell mass in patients non-invasively, and it seems to work. But I'll show those data on Thursday. And I'm now coming to my conclusion. To be honest, after this conclusion, there will be a quiz question. So, how can we characterize metabolic state on an individual basis? I think this is one of the things we should focus on. How can we characterize how can we do a metabolic characterization of patients? You'll use clinical parameters for that and combine them with imaging. This is what I have in mind for the coming 10 or 20 years, what we should develop. Glucose consumption in certain tissues with C13 or MRI or FDG PET, for example. Fat distribution can be done just by looking where is it, but also by looking which kind of fat is found where, like in the MR spectroscopy. Brown fat activation, that's the PET imaging we showed, but there are also MRI probes being developed for brown fat determination. Beta cell mass, beta cell function, what I just mentioned. There's a difference between beta cell mass and function. Mass and function are not equivalent. And also tissue inflammation, inflammatory disturbance of tissue metabolism. That's also very interesting because we can't always take specimens. We can't take surgical specimens of all those things. We have to do some imaging to be able to non-invasively characterize patients. And the question is also, how can we define an optimal combination of clinical tests and imaging? This is something we have to look into. I mean, people in this field, there are not many people in this field, though this will take quite some time, I guess. And for me, an open question is, how can we image the effects of differences in gut microbiome? Because you would like to see how glucose is absorbed in the gut. You would like to see how penetrable the gut mucosa is, for example, for LPS or something like that. No idea how we could image this right now, non-invasively. And also those epigenetic effects might be very interesting to look into, to measure what the consequences on a metabolic level are. So here's the quiz. But I know you pay me back for that, but I had to do it when I saw you standing there. So this is a Caucasian individual, and the question is, by doing what he's doing right there on the balcony, does he decrease his lifetime risk of premature death, or does he increase it? No, that's wrong. So, right, exactly. So this is the answer. It's a risk balance, there's no change. He will not be run over by a car because he's looking on his mobile phone. But he's smoking, which is a risk. But the effect of the beer belly is counteracted by brown fat activation because he's standing outside on the balcony. Okay? So the overall risk balance is 0. And that's it along a little bit from my side. Thank you. I don't know. It's right. It's an hen and egg question. I think we don't really know, but you can induce it after bariatric surgery. So there's some. I think I would believe we all have it, but well, brown adipose tissue. There are some hints in the literature actually that brown adipose tissue is actually an immunogenic organ. It's an immune organ, and that's the interesting thing about it. So it might even be that all those inflammatory processes that play a role in the development of metabolic syndrome originate or somehow influence the brown adipose tissue. So brown adipose tissue is not only adipocytes. I think we all have them. Some have more, some have less. My gut feeling is it's there, but that's my gut feeling. It's not that some people don't have it and thus become obese. That's the same thing as big bones and, slow metabolism, I would say. I think we all have it. But there will be differences. Yeah, but it's also an immune organ, meaning that all those inflammatory processes will have direct influence or even be influenced by brown fat.
But then if we assume that we all have it, then it must be that it's not activated for some odd reason.
Yes. In most people.
Why they would not be activated?
Maybe those same inflammatory processes that cause TNF-alpha production in the tissue, and TNF-alpha will counteract the insulin activity. And I think if brown fat is not activated by insulin, something might happen there. As one example, I don't know. It could also be a nervous system. So it could be innovation. My personal experience is when I'm going sailing, and on a sailboat, at least on the sailboats I prefer, you don't have a heating system. So you're always outside. It's always not the same temperature as inside. And even in the summer, here in the north, it can be, let's say, 15 degrees centigrade. You get used to it. You run around with a t-shirt while it's 15 degrees centigrade. Most people would say t-shirt is something above 20 degree. No, you can even get used to running around in t-shirt at 10 degree. And you're feeling very well when you're doing this. If you take a cold shower in the morning and you sleep in a tent, even if it's very cold outside, you're feeling really healthy. You don't get a cold, at least I don't. This works. So I know that for 20 or 30 years now, and the scientific results of the brown adipose tissue and the thermogenic or thermogenesis experiments actually confirm this. So everybody who hasn't experienced that should try it. It's really nice. So living in our central heating environment is actually one of the big problems we have, most probably, for development of metabolic syndrome.
So with global warming, we're heading all that
I guess so.
direction. Yeah.
Global warming might increase our obesity problem, indeed.
There was a question.
What is your opinion? Because it's true that obesity is a risk factor for many things, but it's also true that a slight overweight is protective for many diseases.
Right.
So how do you think that transition happens? Because it's slightly overweight against normal and against lean, and then once you pass the threshold, you are
Yeah.
no longer protected.
Yeah. I can't really tell you. There are some diseases where you are protected against when you are underweight, actually. So if you have a body mass index of 18, you won't get them. Others you don't get when you're a little bit overweight. And we are not talking about obesitas. We are talking about little overweight. So a body mass index of 20, well, a body mass index of 25.7 is perfect, right? So that's actually a paradox. We believe that overweight will kill you anyway, but that's not true. But what we also know is that your lifetime energy uptake is actually has direct influence on your on your survival, how long you live. So the less you eat, the longer you live, theoretically. I mean, if you don't eat enough, you're gonna die right away. But so it's always a balance. But it is clear that people who eat more will die earlier, not only because of obesity.
Well, not just people, but monkeys and rats as well as
Yeah, right. Yeah, yeah, yeah. It has been proven first in rats, actually. Yeah. Oh, and yeah, it was rats. Yeah.
Any other question?
I want to make a comment. So
You have to change the batteries.
this guy goes to his doctor, and the doctor tells him, you know, you are very high risk of premature death. Oh, so what should I do, doctor? Well, you should stop drinking, stop eating, don't smoke. And the guy says, oh shit, you tell me if I do all this, I will live longer? And the guy answers, the doctor answers, no, I'm sure life will seem much longer.
Right. That's true.
So,
That's true. So the point is, I do drink. I don't smoke. I don't. I mean, when I'm drunk, maybe. So I do drink, and I eat a lot more than I should be eating, and chocolate, and like Ben and Jerry ice, and all these things. But you can compensate for that by doing a lot of sports. So if you go, let's say, so for me, if I go 150 kilometers with my bike, this is equivalent to, let's say, 3,500, 4,000 kilocalories. And I can tell you one thing, you're not able to eat that after your bike tour. A meal of 3,000 or 4,000 kilocalories will kill you right away. So what you're actually doing is that you're getting this energy from somewhere else. Depending on how you bike, it's going to be a fat tissue that's going to be burned or whatever. It's not only your glycogen from the liver that you're using. And you can train that. If you train that, you can eat whatever you want and it's fine.
so that was one of my questions. Don't you think that exercise is more reducing your food intake than actually
It does.
consuming?
Yeah. Your satiety is actually, your satiety feeling is getting better when you exercise and when you're physically active. We don't know how it works actually. Not really. We only have observations, but what the basic principle behind that is, we don't know. But that's definitely the case.
so it could be a brain.
Yeah, definitely. Yeah. Or microbiota. But we don't know. Microbiota, the bacteria in your in your guts.
So I remember when I was once swimming in like athletic team, that after being in the cold water and doing physical activity, like you said about this like sitting naked on the ice and like burning fat, I was always super hungry.
Yeah.
So how can you explain?
Well, I mean, you do need energy. It's physical activity, and it's cold.
And it's cold, and
So you
then,
do
but
need-
then you eat more, but then
But do you eat that much more that you actually gain weight?
no.
Right.
Okay.
That's what I try to say.
So it's enough. So it's together the synergy of doing sports activities
Yeah.
and being in the cold.
Yeah.
And-
Physical activity makes you being less hungry. And we all know this. When I don't do sports for 2 weeks' time and I sit in front of the TV screen, I got my chips or tortilla or whatever, and I'm gonna eat.
Or is it just because you have time to do that? So while you're
I don't know.
hiking, you don't have the cafeteria diet in front of you.
I don't have to drive. I don't have to drive when I'm physically active.
Yeah, it's just a pastime hobby of eating more.
Well, maybe. I don't know. It's difficult to say.
Okay, let's continue this. One more question.
Right. No, Bert, are you going to give your opinion on MRI now? No.
One remark and one question now, because I noticed some response in the audience that apparently my whole career has been demolished now by one picture.
Yeah, sure. That was my aim. That was my aim. And that's the good picture I'm showing. I have others.
That's the reason.
Yeah.
Anyway, but now the serious question. So, I think you made an excellent overview of all the biological processes that are involved on a cellular level. Where should we now go with imaging? except for all kinds of techniques that you show, they're all being used. And now?
Well, that's a good question. We don't know. So what we actually would need is systematic research to figure out what imaging can do in those patients. What you have to, I mean, there is some research out there about fatty livers and fat content in the livers, for example. We know how that relates to other things. But what we actually would need is patients with metabolic syndrome that are very well characterized concerning lab parameters, insulin production, and all these things, and do systematic imaging in those cohorts to figure out where the differences are in terms of imaging. Because actually nobody really, you saw those patients with bariatric surgery from Maastricht, right? So 4 had no brown fat, and after bariatric surgery they had more brown fat. 1 had more brown fat before bariatric surgery. Why? While he responded to the bariatric surgery therapy. So there are individual differences that we don't know right now, and the very moment we will be able to individually tailor therapies for people with metabolic syndrome, I think imaging can play a role. But we are not even in the beginning of that phase, because we don't know enough about what imaging tells you about those patients, because we've never tried. The only studies that are done in 10 or 15 or 20 healthy volunteers versus obese or whatever. It's not big cohorts.
But we, maybe we'll continue this also when you second talk on Thursday. But the thing is that when you know so much about the cellular biology of the disease, so many things have come out. When we cannot develop traces, for instance, for all of these enzymes, that's not possible.
Yeah.
FDG is also not doing the trick.
Right. I have no answer to this. This, as I said, this is food for thought.
Yeah. I suggest we conclude. We saw that French food is very healthy.